Hi friends, today we will see the first stage of labor. The topic we have already covered, but it is a just revision of the topic. So, as we all know, definition of the labor. It is a series of events that takes place in genital organs in an effort to expel the viable products of conception out of womb through vagina into the outer world. Delivery is the expulsion or extraction of viable products out of womb. Delivery may be vaginal, either spontaneous or aided, or it may be abdominal. I hope you understood the difference between labor and delivery. Delivery, it can be a vaginal, either spontaneous or aided. Aided means whether it forceps or vacuum has been used, or abdominal, that means cesarean. But a cesarean is not called as a labor. Labor is moved through vagina into the outer world. WHO in 1997 defines the normal labor as a spontaneous in onset, low risk at start of the labor, and remaining throughout the labor and delivery. The infant is born spontaneously in the vertex position between 37 and 42 completed weeks of pregnancy. After birth, the mother and the infant are in good condition. That is the definition of a normal labor. Normal labor, euthanasia, when it fulfills the following criteria: first, spontaneous onset and a term. Spontaneous onset means without any induction of labor and after completed 37 weeks. Second, with vertex presentation, that means head of the baby is in the fetus is in the lower pole of uterus. Then with undue prolongation, that means the first and second stage should be completed within 12 to 18 hours. Then natural termination with minimal aids. With minimal aids in the sense no forceps, no vacuum, but episiotomy can be given. Then without having any complications affecting health of the mother and the fetus. If we fulfill these 5 criteria, it is considered as a normal labor. Abnormal labor, or otherwise it is called dystocia, any deviation from the normal. That means these 5 criteria, any one criteria is deviated, then that normal is not, then that labor is called as an abnormal labor. Then date of onset of labor. The date of onset of labor, normally it is calculated by 9 calendar months plus 7 days from the last menstrual period. Then 3 P's of normal labor. First one is the power, second is the passenger, third one is the passage. Power means 2 types: primary power, secondary power. Primary power is the contraction. Secondary power is the mother's voluntary pushing. Passenger means the fetus, and passage is the bony pelvis. Then 4 stages of labor. Labor is divided into 4 stages: first, second, third, and fourth. The first stage, it is the beginning of the true labor pain till the full dilatation of the cervix. An average duration of the first stage in a primary it is almost 12 hours, in a multi it is 6 hours. Onset of progressive regular uterine contraction that increases in frequency, strength, and duration. Blood-tinged mucoid vaginal discharge indicating the mucus plug passed. Fluid discharge from the vagina by spontaneous rupture of the membrane. The first stage is again divided into 3 phases: latent phase, that is up to 3 cm in dilatation, active phase from 4 to 7 cm dilatation, and transition phase 8 to 10 cm dilatation. Second stage is start from full dilatation of the cervix till the delivery of the baby. Average duration in a primary it is 2 hours, and in a multi it is 30 minutes. You have 3 phases. These phases are characterized by maternal, verbal and non-verbal behaviors, uterine activity, the urge to bear down, and fetal descent. The first phase, latent phase. It It is the period of rest and relative calm. Fetus continue to descend passively through the birth canal and rotate to the anterior position as a result of ongoing uterine contraction. The urge to bear down is not yet established. Second phase, descent phase. It is characterized by strong urge to bear down as the reflex. It is known as Ferguson reflex is activated when the presenting part is pressed on the stretched receptors of the pelvic floor. This stimulation causes release of oxytocin and provokes greater expulsive contraction. The urge to bear down intensifies the descent progresses. And third phase of the second phase is transition phase. As the presenting part is on the perineum, the bearing down efforts are most effective for promoting the birth. More verbal account about the pain she is experiencing. These are the three phases of the second stage. The duration of the second stage is influenced by many factors like effectiveness of primary and secondary powers. As I told you earlier, primary power is the uterine contraction and secondary power is the mother's voluntary push. The type and amount of analgesia used, physical and emotional condition of the mother, position and activity level, parity, pelvic adequacy, the size, presentation and position of the fetus, the nature and source of support the woman receives. Third stage, it begins after the expulsion of the baby till the delivery of the placenta. Average duration is 30 minutes both in primi and in multigravida. Fourth stage, it is a stage of 1 hour observation following the delivery. So, there are the three P's are power, passage and passenger. Power means good contractions, passage is the pelvis and passenger is the fetus. Cause of onset of labor. The exact cause of onset of labor is unknown, but there are some theories. The first one is uterine distension. At least the uterine distension explains the onset of labor, at least in case of a twin pregnancy. Because of the over distension of the uterus, the labor starts. Second, feto-placental contribution. Activation of fetal hypothalamic pituitary adrenal axis prior to the onset of labor that will lead to increased cortical releasing hormone, that will increase the release of ACTH, that will stimulate the fetal adrenals, so increase cortisol release, accelerated production of estrogen and prostaglandin from the placenta. Estrogen increases the release of oxytocin from the maternal pituitary, and also this promotes synthesis of receptors for oxytocin in the myometrium, accelerate prostaglandin synthesis. As I told you in the earlier classes, oxytocin is already present in the body, but the receptors in the myometrium is not present. So only in the latent phase or in the term only the oxytocin receptors will be present. So the hormone estrogen helps to promote the development of the oxytocin receptors and accelerate prostaglandin synthesis, and it increases the excitability of myometrial cell membrane. And fourth reason, progesterone. Progesterone level falls before the labor. And fifth one is prostaglandin. The major sources are amnion, chorion, decidual cells and myometrium. Signs of impending labor or pre-labor signs. Pre-labor means just before the labor. What are the signs? As we have been in a joint family or something, or the grandmother used to say, oh, your date is nearing, or it seems that you will deliver in this week. By seeing the characteristics, some way, the way the pregnant woman walk or she react to situations, they can identify that the labor is near. That signs are called as the pre-labor signs. Pre-labor signs or impending labor that include lightening. First is lightening. That means 2 to 3 weeks before the onset of labor, the lower uterine segment expands and allow the fetal head to sink lower. So what will happen? Woman will experience a decrease in minor discomfort of shortness of breath, because if before that, when the fetal buttocks may be compressing the diaphragm, so the expansion of the lungs may not be take place, so she might feel a little bit incomfort or shortness of breath. But when the lower uterine segment expand and the fetus comes down, the feeling that the feeling of breathing difficulty will be lost, so she feel ease to feel. The signs include frequency of urination, because the fetal presenting part again going to compress the urinary bladder, so capacity of the urinary bladder will decrease, and this may cause frequency of urination. And uncomfortable feeling of a generalized pelvic pressure. Then leg cramps caused by presenting part of the nerves. The presenting part may compress the nerves which going to the lower extremity, so she may have some leg cramps. Then increased venous stasis producing depending edema. The venous return may not be proper because of the compression of the presenting part on the vena cava, so it may lead to dependent edema. Then vaginal secretions become more profuse. Second one is the cervical changes. The cervix become ripe, that means the cervix is soft, some degree of effacement and dilatation, and it indicates the readiness of the cervix for the labor. Third one, false labor. Painful contraction with no effect on the cervical chain. That is the false labor. Patient may have the abdominal pain, but there is no change in the cervical changes. So that is the false labor. It may occur for days or intermittently for 3 to 4 days. Then premature rupture of membrane. Normally the rupture takes place at the end of the first stage. It may due to the ill-fitting part of the presenting part. Then bloody show, a mucus plug created by the cervical secretions from the proliferation of the glands of cervical mucosa early in pregnancy, serves the function as a protective barrier early in the pregnancy that will be lost in the beginning of the labor. Then energy spurt. For 24 to 48 hours just before the onset of labor, she may feel that she have a lot of energy, lot of things to be done. That energy spurt will be there. These are the then GI upset. In some cases, the patient may get a small amount of GI upset, means diarrhea or vomiting. All those things will be formed. These are the some of the impending signs of labor or pre-labor signs. Then you might have heard about the term upper uterine segment and lower uterine segment. The thick upper uterine segment is the muscular part of the fundus. This part bears the contraction and retractions and transmit it into the lower uterine segment, so it allowing the mechanical stretching. With increasing the uterine contraction and retraction, ovoid uterine fundus elongates more and reduces the transverse diameter. Lower uterine segment. Before the onset of labor, there is no complete anatomical or functional division of the uterus, but during the labor, the active upper uterine segment and a passive lower uterine segment is more pronounced. The wall of the upper uterine segment is more thickened with progressive thinning of the lower uterine segment. Anatomically, the lower uterine segment corresponds to the part of the uterus to which the peritoneum is loosely attached to the anterior wall. When fully formed, it measures nearly 7.5 to 10 cm from the internal os. It is hemispherical in shape at the beginning but becomes cylindrical when fully formed in the second stage. Thinning is achieved by the relaxation of muscles fibers causing elongation, as it is entirely passive. The contraction and retraction of the muscle fibers of the upper uterine segment, thereby drawing up and elongating the lower uterine segment and cervix. Unlike upper uterine segment, has got poor retractile property. Then clinical importance. The clinical importance of lower uterine segment. The phenomena of receptive relaxation enables the expulsion of the fetus by formation of complete birth canal along with fully dilated cervix. Second, implantation of placenta in the lower uterine segment give rise to a clinical condition known as placenta previa. Then third, it is through lower uterine segment the cesarean section is performed. Fourth, Because of the poor retractile property, there is a chance for PPH if the placenta is implanted in the lower uterine segment. Then, poor decidual reaction facilitate morbid adherent placenta. That means, if the in case of placenta previa, it may lead to morbid adherent placenta. Then, in obstetrical labor, the lower uterine segment is very much stretched and thinned out and is likely to give away, especially in multipara. Then physiological change process in the first stage of labor. It is divided into two: mechanical actions and uterine actions. We will see the uterine actions. First, the fundal dominance. The contractions begins in the fundus, then it spread across and downwards the body of the uterus. It is maximum intensity at the fundus. This is known as fundal dominance. That means the contractions start in the fundus, then it is spread to the lower part of the uterus. So that is known as the fundal dominance. Second one is polarity. Polarity is the neuromuscular harmony between two poles of the uterus. That means the upper uterine segment is meant for the contraction and lower uterine segment meant for the dilatation. It should not occur in the opposite way. So that is the neuromuscular harmony between the upper and lower uterine segment. Then contraction and retraction. Uterine contractions are involuntary. They are controlled by nervous system and endocrine influence of the woman's body. During labor, the contraction does not pass off completely after the contraction and it retains some amount of contraction. It is the unique property of the uterine muscle. In this process, the upper uterine segment of the uterus becomes gradually shorter and thicker, and its the cavity shorten in size. When the labor begins, the contraction occurs every 15 to 20 minutes for 30 seconds. The beginning contractions are weak in nature and gain rhythmic regularity with a pause in between. The very strong contractions have a set pattern of recurrence every 2 to 3 minutes and last for 50 to 60 seconds at the end of the first stage. Fourth one is formation of upper and lower uterine segment. The upper more muscular mainly deals with the contraction and lower is thinner and distension and dilatation. We already seen what is upper and lower uterine segment. Then fifth one is retraction ring, a ridge between upper and lower segment. Normally it is not visible over the abdomen, but during the obstetrical labor it is prominent over the abdomen and that time it is called as Bandel's ring. Then cervical effacement. The term refers to merging of the cervical canal. That means during pregnancy there is no change in the length of the cervix and the length of the cervix is unaffected throughout the pregnancy. But when the labor starts, the cervix is slowly going to merge in the lower uterine segment. That is known as the cervical effacement. Then thinning of the cervix and shortening of the cervical canal. Effacement expressed in terms of percentages like 50%, 80% and 100%, which is paper thin. Then seventh uterine action is the cervical dilatation, the process of enlargement of cervical os from few millimeters to the opening large enough to pass the baby. Dilatation occurs following softening of the cervix, increase the vascularity in the cervical region and the effects of the strong uterine contraction. Then a well-fitted presenting part and bag of waters play a major role in the presence of dilatation of internal os. Pressure of the uterine fundus, counter pressure by the hindwaters and the fetal axis pressure are dominating factors leading to early arrival of the second stage. Then eighth one, ripening of the cervix, the process by which the cervix becomes soft, compliant and partially dilated is termed as cervical ripening. It is the combination of biochemical, endocrine and mechanical factors means ready for the job ahead. That is the meaning of cervical ripening. Then these are the 8 factors which comes in the uterine actions. The second form of action is the further changes in the first stage of labor is the mechanical factor. Among the mechanical factor, the first one is formation of forwarders. The lower uterine segment stretches as a result of strong action of the uterine muscle. The chorion membrane detached from the walls and bulge out in a wedge-shaped bag is known as bag of water. It helps further dilatation of the cervical os. A well-flexed head fits well into the cervix and cuts off the fluid in front of from the hindwater in which the body is floating. Second term is general fluid pressure. During uterine contraction, there is a lot of pressure on the fetus, the membrane, the placenta, the umbilical cord, and the amniotic fluid. The pressure of uterine contraction is equalized throughout the uterus if the membranes are intact, because the bag of waters counterbalance the pressure of uterine contraction, and this is called general fluid pressure. In this, the fetus, placenta, and umbilical cord don't get compressed in between the contraction. Due to the rupture of membrane, some of the amniotic fluid drains out, leading to interruption of the supply of the oxygen to the fetus. Therefore, it is essential to preserve the integrity of the fetal membranes to regularize the supply of oxygen to the fetus, as well as to occurrence of the infection, especially in case of prolonged labor. The third one is rupture of membranes. Ideal time for the rupture of membrane is the end of the first stage of labor. Once cervix fully dilated, it gives no support to the forwarders. Artificial rupture of membrane be carried out using surgical forceps. Early rupture is always harmful if the presenting part is ill-fitting. It may lead to dry labor, rate of infection may increase. At times, the membranes may not rupture even in the second stage, and the fetal head covered with a sac appear along the fetus called cord. Increased incidence if the cesarean section have been reported after rupture of membrane due to variability in these relations on CTG. Fourth one is fetal access pressure. It is the exertion of the force on the cervical canal of the mother. During contraction and retraction, the maximum intensity of contraction is retained in the fundus and gradually transmitted downward to the presenting part, which in turn applies a force over the cervix. Fetal access pressure has specific role to play in the second stage of the labor. The uterine contractions are the primary power to expel the fetus. Each contraction is described in terms of frequency, intensity, duration, and resting tone. Frequency means how often the uterine contraction occurs, the time from the beginning of one contraction to the beginning of other contraction. Intensity, the strength of contraction at its peak. Duration, the time that between the onset of contraction and end of the contraction. Resting tone, the tension in the uterine muscle between the contractions, relaxation of the uterus. It can be divided into mild, moderate, and strong. This mild means slightly tense uterus as if we had touched the tip of the nose, and the duration of this contraction is less than 20 seconds. Moderate, firm fundus, difficult to indent with the finger. That means it is between 20 to 40 seconds of second duration. Strong, board-like fundus with impossible to indent with the fingers as if you are touching on your forehead. That is above 40 second duration. So recognition of the first stage of labor. Recognition by the mother, that is the show will be there, contraction will be there, and the rupture of membrane then. There is a difference between true labor pain and false labor pain. True labor pain begins irregularly but becomes regular and predictable. It begins irregularly and remains irregularly. True labor pain first felt in the lower back and sweep around to the abdomen in a wave pattern, but in false it felt first abdominally and remained confined to the abdomen and growing. True labor pain continue no matter what the woman level of activity. False labor pain often disappear with the sleep or ambulation. True labor pain increase in duration, frequency and intensity with the passage of time. But in false labor pain do not increase in intensity, duration or frequency with the passage of time. And true labor pain accompanied by shock False labor pain show is absent. True labor pain, it achieves the cervical effacement and cervical dilatation, and false labor pain do not achieve the cervical dilatation and cervical effacement. Friends, here we are coming to an end of the first stage of labor. The remaining we can see. If you have any suggestions or comments, please let me know.